it to the web in the future. Also like to just remind everybody of a little bit of Teams etiquette. We don't use the chat function in this meeting, so if you want to contribute, ask a question or anything, please pop your hand up. I'll keep an eye on those hands, and so will Ruth as well. And just if everybody could remember to stay on mute unless you're contributing, just helps with the sound. It's lovely to see everybody's faces. If you're good to keep your camera on, but obviously if you're having trouble with your Wi-Fi, you can switch that off. That sometimes helps as well. And of course, welcome to any members of the public and press. Thank you for taking the time to be here. So before we start, I am delighted to announce that Fiona Davies has been appointed to the position of Chief Executive. And on behalf of all of the board, I'd like to express our congratulations to Fiona. Fiona's going to take up her position on the 1st of April, when Pam will be taking her retirement. As probably most of you know, Fiona is currently our Chief Officer in Argyll and Bute for the Health and Social Care Partnership. She has a wealth of experience, clinical, professional leadership and operational and strategic management roles. Fiona has actually worked for NHS Highland since 2012 and has a particular interest in delivering health and social care in remote and rural communities, which is very good for us. Fiona's been an excellent leader in Argyll and Bute in the Health and Social Care Partnership. I had the privilege of working with her when I was chair of the IJB, and I look forward to continuing to work with her in her new role. We have some other announcements as well. It's all happening in 2024. Evan Bezic has been appointed as the interim chief officer, so filling up where Fiona's going to leave off in Argyll and Bute, and again he will take up that post on the 1st of April when Fiona formally leaves that position. We have another appointment to celebrate as well. I'd like to welcome Richard MacDonald to the meeting in his new capacity as Director of Estates, Facilities and Capital Planning. Richard formally took up his new role on the 22nd of January, but he's a familiar face. Most of us will know him around the board table as he has previously been the deputy to his predecessor, Alan Wilson. So it's lovely to have Richard still with us, but in that new capacity, and we look forward to working with you, Richard, in that new role. And finally, this is the first board meeting officially for our new non-executive directors. I'd like to extend a warm welcome to Steve Walsh, Karen Leach and Emily Willard, who all took up their roles with us in December. All of our new non-execs are undergoing various induction meetings and getting to know the organisation, which is no easy thing to do with somewhere so large and complex. And they have been coming to different meetings. You might have seen them as observers. They're going to make a great contribution to the board, and I'm sure we will all give them all the support and a warm welcome that they need. So that was a lot of news to start us off with, and we'll get stuck into the main agenda. So first of all, apologies, Ruth.
Thank you, Sarah. Yes, we have apologies today from Anne Clark, Katrina Sinclair and Gaynor Roger. And I'm also aware that Brian Williams will be joining a little later this morning, so he's not with us right this moment. So I'm not sure if there are others to be announced.
So I think Louise might be a little bit late joining, and I think we have a couple of people that might need to leave early. I think depending on how we do for time, Heleth might need to leave us, I think about 12:30. Dave might need to pop off, and we've got apologies from Pam Kremen as well. She can't be here today. I think that was all of them, wasn't it, Pam? Yeah, great. Okay, declarations of interest. Alistair.
Yes, good morning, everyone. I had considered making a declaration of interest in my capacity as a Highland councillor, but having applied the objective test and looking at my connection to the items on the agenda, I feel I don't need to do so. Thank you.
Thank you, Alistair. And Steve?
Good morning, Chair. Good morning, everyone. I also considered making a declaration as an employee of High Life Highland. I've applied the objective test to the agenda and the declaration isn't required. Thank you.
That's great. Thank you, Steve. Okay, I'm not seeing any other hands up to make a declaration of interest, so we'll move on to item 1.3. So these are the minutes of our previous meeting, which was held on the 28th of November, and the associated action plan. So first of all, I'll just check, does anybody have any points of accuracy for those minutes? Just check myself, I haven't made any notes. No, I'm not seeing any hands up there. Are we happy to approve the minutes as an accurate record of our meeting? Great. Okay, let's have a look at the action plan. Sorry, doing a little bit of a go slow, bear with me. Oh, sorry, my computer is not playing ball today. So while I wait, is there anything in particular we need to pick up from the action plan, Ruth?
Hello there. Well, there are a few items on the action plan today. Two of them are proposed for closure. The one relating to the IPQR, board members received information about the drug and alcohol improvement plan at the last meeting, and they received something given to them after the meeting as well. And the risk appetite item, that's item 16 there, that's proposed to close. Annual review of your risk appetite will be included on your work plan. There's an item on there at the moment about corporate parenting, and corporate parenting had originally been planned for this meeting, and I'm aware it's going to be delayed until the March meeting. I'm not sure if Tim might want to add a little bit of context to that.
Thank you, Ruth. We've been engaged with corporate parenting more so than sometimes in the past, and with the Promise board within Highland area, and of course we've got corporate parenting both within Highland and Argyll and Bute, and the agenda item relates to Highland HSCP. The capacity to complete the action plan and to fully report back to the board's been limited by the lack of a child health commissioner, but I'm delighted to say since the start of the month we've had Debbie Stewart, who has moved from the position of alcohol and drug partnership coordinator and now taken the post of child health commissioner, and that's high on her agenda to do for the March board. As it happens, it will, I think, fit a little bit better in the March board than in the January board, since a lot of the actions are due to be completed by March, and rather than saying that they're still in progress, I'm hoping that we'll be able to report that they're completed.
Thank you, Tim. And I had a lovely introductory meeting with our new commissioner, and that was great. She's totally taking up that role with enthusiasm. Are we happy then to do as what's been proposed? So that's to delay the, sorry, Alex, you've got your hand up, beg your pardon.
Yeah, the other one is action one, which is the National Care Service. Now, to be honest, that's been overtaken by events. So what I would suggest is that is suspended until such time as we know what's happened. We can't say it's completed because it isn't, but by the same token, it's sitting there over a year out of date, which doesn't look particularly good. So I would suggest we suspend that one, and then once we know what's happening, clearly that's going to be brought back on if and when. Thanks.
Yeah, thanks, Alex. And I wonder if, and maybe we take this away to think about how we do it, but I wonder if actually that's amalgamated more broadly into risks we hold around kind of transformation and changing the shape of things given where it is at the moment. But I think that's a really good point, because it could just sit there not doing very much, which isn't helpful for us at the moment. Lorraine?
Yeah, I'm happy to take that away and think about how we incorporate it in the corporate risk register wider, about changes and reform at a national position, because I think there's lots to come in that space, so we maybe need to reflect that corporately.
Thank you, Lorraine. That sounds good, actually. Okay, are people happy with that? So we've got the two that are proposed for closure, we've got the slight change to the corporate parenting, and the the piece around the strategic risk register and the National Care Service. Lorraine will take that away and have a look about how we capture that more broadly. Are people content with that? Okay, fantastic. Okay, so that's been noted and we're happy with those proposed changes, sorry. So that takes us on then to any matters arising. So just to check in, we've obviously got a few things on the agenda today that we need to talk about, but just to check if any members wish to raise anything from those minutes that are not already on the agenda. No? Okay, great. So item number 2, I'm going to hand over to Pam, and Pam's going to give us her Chief Executive report. It's a good opportunity to get an update on kind of live and emerging issues so that we're all sighted on where we are. So over to you, Pam.
Okay, thanks very much, Sarah, and good morning, everyone. I'll probably just start off by just endorsing and congratulating Fiona in coming into the post. My last working day is our next board meeting. So I think I started in NHS Highland on a board meeting, so finishing on one. Fiona and I have worked out quite well together how we manage the transition so that that's hopefully as smooth as possible for the organisation, and I have to say that is a real kind of privilege and an opportunity that we're often not afforded. So I think that that's really positive for the organisation. So just to give you that assurance that we are working together now in terms of making sure that that 1st of April isn't an April Fool, that it is actually a good start to taking up post. So that's all good. Got a few things to go over, but I guess the main thing that I want to talk about or say a bit about is our financial position. And obviously we have been putting out to staff and to communities and stakeholders some communication just around the position, and particularly urgent was to get out the position in relation to capital. So following the December budget statement, the 19th of December, we were then very aware of the impact that might be for NHS Highland alongside other boards in terms of that settlement, and in particular, if I start with the capital, the clear instruction that we received around the real challenges with capital and the fact that we would not be receiving the funds that we would have expected to progress with the new developments that we had in hand. I guess the uncertain piece is when that will become available again, and when that will start up again, and the kind of information we've been given is that it is at least 2 years away, and I guess we just have to work in that uncertain space. Obviously, that affects the Caithness redesign, the Lochaber redesign in particular, the new hospital, the maternity refurbishment, and the Kyle Community Hospital development. Really significant for all those parties involved, and we've worked really, really well with those communities to try and get to the right place and to work with them around co-designing what the future looks like. So very disappointing for communities, but unfortunately in the state of play with the finances nationally, that is what is happening right across the country. So we have tried to ensure that everybody who is affected understands the position and what that means, and we are in I guess regular dialogue at the moment with all those parties who have an interest and who may have a concern, whether that be politicians, local councillors or communities themselves and our staff. We, however, even in the kind of wake of that, the revenue position continues to be a massive challenge for us and other boards. And Hileth and the team have been working hard on what this means in terms of the settlement, and you'll hear more about that later when Hileth does her report. And I guess we are absolutely working on, what is the worst case scenario and how do we plan for what that might mean and what change might need to prevail. That means a lot of work at pace, because in terms of the recovery plan that we had, which was over a 3 to 5 year period, we are now tasked with looking at how we can do that as quickly as possible, and certainly what there is a strong expectation of us achieving a significant improvement and balance next year. So we are in the throes of understanding the implications of that, what that would take, both in terms of what we would see as good and positive and reasonable changes in redesign, as well as what that might mean for the future of a footprint of a health board in a remote and rural context. That's not to say that those are decisions that will be taken. So I think that's really important, but it's important that we set out what this means for the future now, so that we understand as a board, but also the government understand, and then hopefully good decision and choices can be made relative to what this means. I think it's a good opportunity for us to set out the cost of running a health and care system in a remote and rural context. It's a good opportunity for us to understand both internally and with partners what the art of the possible is, but most importantly, it's a great opportunity for us to involve our staff and to involve the communities that we are already connected with through particularly these redesign projects, and keep working with them to solve our dilemmas and to think differently. So we have to take it in that spirit and try and move forward in that way. That doesn't mean that's going to be easy, and I think when you marry that to the pressured system that is being experienced at the moment, that's not an easy task. So working with our staff side partners, and also with, as I said, wider partners, we need to support our teams to understand how we work through this, how we generate ideas, but then how that is taken to decision making. And generating ideas doesn't mean decision making, and that's a difficult and tricky place to play, if you like, because the minute you start talking about something, people get nervous that that's actually what's going to happen if they don't think it's the right thing to do. So it's going to be a tricky space for leaders to operate in, but it is absolutely the leadership task in hand, and we know that. And we have lots of different ways that we are trying to look at this in order to stimulate thought and ideas. We have known about this and have been trying to understand how we reform in this space, because I think, as we've said plenty of times before, whether we had all the money in the world, the workforce shape and challenge is a daily challenge for us, even if we had the money. So this is back to, the big question, what strategically is the future shape of health and care in our board area and indeed in Scotland, and we all have a part to play in that. So it will be very challenging, but equally it is a space where we can innovate. We will have to manage and support our teams through this, because at a time when they are struggling and concerned about quality and safety, we need to make sure that that balance of risk is present, that we absolutely couch our decision making against quality and safety and not doing harm. And that those points have been raised directly with me, following on from the messaging that I put out last week from frontline staff. So, so there's both opportunity and challenge in this, but we will continue to probably have to manage this quite closely, provide positive leadership, but equally be able to set out as a board what this means and where the appetite is of the board in terms of risk appetite, and with our government colleagues where the risk appetite is nationally in terms of where decisions are taken and supported. So a huge amount of work ongoing for us. It's really stepped us into a different level from what we were planning against, and I certainly wouldn't underestimate that challenge at all, but that hopefully that sets out the kind of breadth of what needs to be done, and that we can hopefully retain the relationships we've got with our communities and continue to work on the shape of services, because regardless of the capital, we still have to address what the shape of services will look like. That redesign doesn't go away whether there's a capital project or not. So I'll pause there in case there's anything at this point. Obviously, we're going to have our paper on finance, which again will take us into some of the figures and some of the assumptions, and there'll be the opportunity to discuss things then too.
Thanks, Pam. And I suppose also noting, although it's not just about finance, as you've highlighted, we have stepped up our FRP committee, so we're looking at this much more regularly and in much more detail, because obviously we need to be very close to this, given how difficult it is. I'll just add before I bring Graham in, to reflect conversations that I've been part of nationally. This is a problem or a challenge across the whole country, and as Pam said, that need to redesign how we deliver services was already there, and is true for all boards. Just now there is a kind of a more urgent pressure around the finances, and as Pam said, that remote rural element for us, which is really, really significant. But I suppose what I would say, having taken part in some conversations yesterday, is the recognition of the opportunity that is out there. If we can have those honest and transparent conversations about how we could do things differently, and that's not just within our own area, but regionally and nationally, and looking beyond those traditional borders for opportunities to work together, because we're not the only ones facing the challenge. And I think we need to be very open to considering all the opportunities that are out there, and really just thinking very differently about how we do things so that we can have sustainable services. Okay, I'm going to bring Graham in next, please.
Thanks, Pam. I'm sure we all share that disappointment, particularly on the capital side, recognising the the kind of long-term implications that add costs and so on when you delay capital. But I'm interested in, I suppose, the redesign issues that have to take place, because not just because of the budget, but obviously to try and provide better services. One of the things that I think it's fair to say across the country is that we've been trying to harmonise and make sure that there aren't huge variances and disparities in different parts of the country. And I'm conscious that there's only so much that a local board can do, unless there is very kind of clear guidance coming from the Scottish Government on what the parameters are of the changes that we have to make. And I'm just interested in what's coming out from government, that kind of guidance, and whether there's any plan for non-executives as well. Thanks.
Okay, in terms of the engagement of non-execs, I don't think at this stage that we've had, unless Sarah, you've got anything to add to that, other than at board level, but that might well be something that comes. I think the position that we're in at the moment is obviously working very collectively as chief execs and all our other lead board members, such as the medical director, nurse director, finance director, all those groupings coming together, and indeed with I think a strong eye to the public health messages and prevention. So there's a lot to balance here, because the decisions we take now could have a knock-on effect on unintended consequences around some of the important things. So there's that. I always describe it as what's the urgent versus the important, because in tackling the urgent, you can inadvertently impact the important in the longer term. So that all those groupings are, discussing and debating, what might be an approach. We have got some guidance coming through in terms of areas to consider, and that's what we're working through at the moment. The idea will be, and Heleth will say a bit more about this, and it isn't just about the finance, it has to be about what this does to our system, and ultimately, just as you're describing, Graham, what does this do in terms of outcomes for people, and what does that do to how the system works in terms of access, and thinking about inequalities and poverty. Everything we decide here has to take cognizance of the fact that our current population profile is one of a widening inequalities and a cost of living crisis where poverty prevails. And so there's a lot to tee up, and a lot in a short time. Although we're not starting from scratch and we're not starting from a no knowledge, it's the choices aspect, and that is the language being used that I think is going to become stark. You know, how do we as a country make sound decision making that is the best we can do with what we've got, and how do we not just make that so insular that we miss the opportunity of working with our partners and communities to be innovative in that space, because that is the task in hand. And I know that's really difficult when we're experiencing the pressures we're experiencing, but strategically we still have to keep that kind of line of sight, I think, in everything that we're doing. So that collective piece of understanding what different boards are looking at, of what the appetite is nationally for where things land and how we make good decisions together, is what we're trying to hold on to. But that's a very easy thing for me to describe. In practice, that is going to be challenging, and I think it probably speaks to how we have our conversations in the coming weeks and months as a board, and how we feed in what we're learning, both from our internal discussions and from our frontline staff, as well as what we are learning from wider system thinking and changes. Lorraine is working nationally a day a week with the planning team nationally, so that's a really good connection for us in terms of being right in amongst that thinking and actually influencing that thinking through Lorraine's connection there. So, you know, we're trying to join it up as best we can, and play at all levels to get the best possible outcome. But there's no doubt it is going to be a tricky period.
Thanks, Pam. And I'll quickly pick up the point, Graham. So I think obviously all boards across Scotland are going to be thinking about how they manage the communications around this, how they engage with staff, how they engage with communities, how they have those difficult conversations. And I think whilst there isn't a kind of a plan to do that in a bespoke way, that'll happen in the normal way. I think what I am hearing more nationally is that, you know, we're all, what's that expression, you know, we're all in the same storm but different boats, so we all have to think about how we're messaging it that will be unique and appropriate for each of our areas across Scotland. But you know, there is a commonality there that we need to pull together, and indeed as we start to look at opportunities that are out there across the country, you know, that means more and more that our messaging does need to be joined up. And I think what's interesting for me is that you know, previously the idea of a national conversation about the shape and the future of our services has been talked about before, and I think almost this is going to start happening anyway, as all the boards and not, of course, we're talking about NHS and health services, but local authorities as well are having those conversations with their communities about how do we do things differently, given not only the financial pressures but those workforce and sustainability pressures as well. So sort of, to not really answer your question, Graham, I suppose there isn't anything that's been planned specifically, but it's happening quite organically, I think, and it's gonna continue. I'll bring Alex in next, please, and then Bert.
Thanks, Sarah. Yeah, Pam, I share the disappointment in the capital and the instruction that we received on that. But I'm also concerned about the fact that although the Deputy First Minister said the NHS was protected, our actual allocation for this year, I believe, is exactly the same as last year. In other words, it's flat cash. So we've got to do more with less once inflation, etc., is taken into consideration. Has there been any indication that that's going to happen again in the following years, or do you think this is a one-off and things will go back to normal beyond this? Thanks.
I think that might be quite a good one to pick up when Heleth's going through her report and what sort of assumptions are being made there. I think we are in tricky times for a period, not for a short period. Would be the kind of short answer to that. But we can pick that up when Heleth's looking at some of the planning assumptions, Alex.
Thank you. Bert, I'll bring you in next.
Thank you, Chair. Good morning, everyone. Pam, yes, a very difficult situation that we're facing, and likely to be for a number of years to come. I think it's very positive that Lorraine is engaged in that national piece of work. I think that can only be beneficial. My apologies if I missed this, because I had to leave the meeting just very briefly, and you may well have covered it, but I'm thinking about the opportunities for regional working and collaboration with boards across the north and the northeast of Scotland. And as I say, you maybe did cover this, but I just wonder what the opportunities are for that work, and what that might do to help the budget approach. Thank you.
Yeah, thanks, Bert. So we are looking at every level, both regional and national, in terms of what the opportunities might be, and we are seeking to understand further where they sit. So there are different drivers and different motivators around different things that could be a solution, if you like. So some of our more, I guess, fragile services, where historically we've managed to work in a particular way that has allowed us to do particular procedures, and oncology would be one of the ones that we've talked most recently about. The difficulty we had having nationally, that is recruiting oncologists, and there are other specialties that could come into that arena. There's real thinking needs to go into what the sustainable model is, and again, that's less money driven, that's more workforce and specialty availability driven, in terms of what the decisions might be as to whether that becomes a national approach to solving the problem, or whether it can be done in a regional context. So we're exploring all levels, would be the short answer to that. And we've got regional arrangements, monthly meetings as chief execs, again, our medical directors, public health directors, our states directors. We have a number of mechanisms to bring us together to understand the opportunity and the limitations. But absolutely, we need to look at what the best way to take the public pound and to organise the workforce resource, which is our main resource for delivery in that space, and make sure that we are optimising what we can do for people first and foremost by deploying that to best effect. And that could be a national service, that could be a regional, or it could be something we hold locally. So we have to play in all three levels.
And I'll just add to that, I suppose, actually, so regional working is not new. It's been kicking about for a long time, and I suppose ever the optimist. I think what I'm hearing now is a difference in the kind of the tone of those conversations about regional working, because we're being, there's a catalyst, isn't there, to us to really consider how we do it differently. And I think that level of pressure wasn't maybe there before in that regional space, and I think it's a good thing in that context, that we're having to seriously consider how we might make the best of those opportunities. And of course there are challenges as well, true, and we are not entirely unique, but a little bit special in that we sit in that north region, but we also sit in that west region as well. So we've, I suppose, twice the regional work, but twice the opportunities, perhaps. But so we need to remember that we, because we are so large and we cover such a huge area, we link into both of those regional areas, and I think that will hopefully give us some opportunities in our different localities to think about how we do things, but will require significant partnership working in a way that, and a scale that we haven't seen before, I expect. Muriel, I'll bring you in next.
Thank you. I think, Pam, you mentioned all the partners that we're working with as a team. Our Scottish Ambulance Service, the transport helicopter lifts, because of obviously our geography and our island diversity as well, are they part of this looking at a way forward?
Yeah,
Yep.
absolutely. And nationally, regionally and locally, but locally we've got very strong relationship with SAS and the retrieval services, and you know, everything that we look and plan to do involves them, and I've had very positive feedback about how our teams engage.
Sorry, my mute button got stuck there. Thanks, Pam. Thanks, Muriel. Lorraine.
Yeah, I guess just to give some context to that work, what we're looking at nationally is really population health planning of clinical services, and from a place-based approach, what is appropriate to be delivered through the National Clinical Framework in that way, and then what do we need to look at on a local or regional or national basis. What we've, I guess, explored so far is that a lot of the services that we're challenged with in the north are replicated across the country. So some of the solutions may not be just within our regional borders, but look into a national approach, especially looking at what digital connections we can create for our clinical colleagues across the system, which we have seen with oncology. There's a number of work streams being established around oncology. Vascular, you'll have heard at the Clinical Governance Committee, is also a significant area, but then so is diagnostics, which we'll see replicated in our cancer performance with the number of referrals. So some of these solutions might not be based regionally, which is why we're trying to support that approach nationally, but then look where appropriate that it is regionally or locally delivered. I think that just the sustainability of our clinical services has really come to the fore, because a lot of services have been escalating that to Scottish Government. So we have to look at a different approach nationally, which is what I'm supporting Scottish Government with at the moment. And definitely for Argyll and Bute, you know, in that remote and rural context, then our SLAs and visiting services is also providing a challenge for our island boards as well. So how do we do that differently moving forward?
Thank you, Lorraine. That's really helpful.
So I've got a couple of things. I've got a couple of things to say about the finance, Sarah,
Yep.
just to finish off, and then I've got a couple other things, if that's okay. I'll try and be brief on the others, but so in what we mustn't lose sight of in all of this is social care, and so we're a lead agency and we're a partner in an IJB, and social care is a critical part of the work that we do. And just to go back to Alex's point about the NCS, which at this point is, you know, going through a process that will, you know, take some time, I think, for us to see any effect on change. The big question is in the here and now. What's going to happen. Obviously working with both councils through their statutory responsibilities for the delivery of social work and social care is an important partnership, and obviously that has an effect on our system, both from a quality and safety perspective in terms of people. I will not use the words to describe people as delayed discharges. They are people who are not in the optimal place for them to do well, and that is something that a situation we don't want to be in. We want everybody to get the best outcome through getting the right care in the right place, and we'll continue to strive for that. But the social care and the support that the social care sector need in order to be able to respond to the needs of individuals is still well out of kilter as well, and something that we are raising both nationally, and we will continue to raise with our council colleagues in relative to their statutory responsibilities. And obviously the challenges for councils is that, you know, their funds are limited as well, when the cost of care, particularly in remote and rural settings, is a lot and is high. So we will continue in those discussions, but we do have a real challenge there, both in keeping the workforce motivated, keeping people engaged in working in that system, and ensuring that we understand that balance between what we as a health board put in and around our health aspects of integration, and how we work with the council to make what will be very difficult decisions as well around what this means for care in our community. So there's a lot to work through there, and it's a really important aspect. And sometimes our social care colleagues don't feel that they're very prominent in the dialogue around health. So we really need to make sure such an important component of our success is a robust and stable health, social care sector. So lots to do in that space. And I suppose our staff, that welfare aspect, that resilience aspect, that ability for them to feel able to have a voice in this space is going to be really important. But equally, us trying to help people understand the world that we live in and how change needs to happen when maybe they haven't had much exposure to that before. And then back to how do we continue to work with our communities. The last meeting we had with Lochaber, and I was asked to go to Lochaber question time, the comment was how well we were working with that community, and there was no questions for me actually as one of the public sector panel. That was a really, really positive place to have got to with the community. What we mustn't do in this arrangement is lose that connection, and to help them continue to be part of the solutions and ideas and understand what we're trying to do. And also, I guess just back to those projects, there's a lot of work being done around the big projects, and we don't want to lose that. We want to hold that so that when capital becomes available again, we are kind of good to go, not throwing all the work that we've done out the window. We're not starting from scratch. We've got to keep that line of sight there. I think the maternity refurbishment is going to be hugely disappointing for our teams. We know that was something that we were very pleased to get the support to do, because our maternity facilities are really needing brought up to today's standards, and that was an opportunity to do that. So we are at the moment just working through Catherine, through the programme board, the joint programme board with Grampian, to understand the impact of that and what that means in terms of that arrangement. So there'll be more to come on that, but I'm sure for our teams that's hugely disappointing, understandably disappointing. When we were actually due to start that, I think it was last week. So it was so live for people that will have I think an even bigger impact. So just to make those points. Obviously, we'll talk more about finance when we come to Leth's item. A couple other things. Vaccination, we continue to look at the future model for vaccination and to understand what the different options might be. Again, people are used to delivering things in a particular way. We need them to think a little bit differently. The key aim of our vaccination at all ages is to improve our uptake, increase a positive outcome for our population at a local level. So again, a person-centred and place-based approach is our guiding star. And so we need to work out how we ensure that we've got the expertise delivering at a local level, and what the best way is to do that within a very challenging workforce situation. I'm not going to use the finance. It's again, if we've got the workforce appropriately trained and placed in the right places, and clarity about the expertise and support that needs to be in place, and that can be formed in whatever way is best, then we hopefully can get those outcomes reliably the way we need them to be. Obviously, the MMR and the measles threat is a national challenge. What's been seen happening down south is not something we want to see replicated in Scotland. It's not just a professional issue, it's a societal issue. It's about really linking with families and parents to understand how we make that easy for people to get their child vaccinated when indeed they are making the choice to do so. So we recognise some of the headlines. However, there is a national issue around this, and there is also a local improvement that we are committed to in and around the same principles as I've just described. So I just thought it was important to kind of say something about that. So I'm going to end on a positive note, so because you know what I'm like. So we had a letter come in just at the end of last week. So HMP Inverness and the healthcare team there, again, probably a team we don't hear a lot about, but who provide an amazing service to those people in custody in the local establishment. Were subject to an inspection in August 22, and out of that, as is normal with inspections, there was an improvement plan, action plan. They were reviewed just a couple of weeks ago, and they have been signed off and have made significant progress around the recommendations made, and there is no follow-up. So they are very pleased with what that team has achieved, and I think that's great. So well done to them, because that's a challenging environment to work in with. You know, you need the motivation and the teamness there is got to be really cohesive and good to have achieved that. So that's great. And just on the back of that, Paul Rusk, one of our team leads in the custody team, has been nominated to join the Queen's Nursing course, which programme, which is, you know, a really a programme where people of high calibre, individual nurses who have demonstrated a high commitment to patient care and nursing practice, get selected to go through that Queen's Nursing programme. So again, we obviously have had some people that have already completed that, and it's a huge accolade for nursing. And just to note that it's really good to see it. I think we saw it going into mental health last time with individuals who have been engaged there, and it's great to see that in custody as well, that we have a Queen's potential Queen's nurse in that arena. So really good to hear something from a different part of our sector and remind ourselves of the service and the great service that's delivered there. So thank you.
Thank you, Pam, and absolutely congratulations to that whole team on all that work. And it's right, it's really good to hear that. Okay, so lots in that update from Pam, and I'm sure we're all processing it. As Pam said, we can dive more into the finance when we get to item number 4. And I'm not seeing any other hands up. So thank you, Pam. We've gone a little bit over time, but I think that was a really important discussion to have, and I'm really pleased that we were able to pull in some positive aspects of what's happening in NHS Highland at the same time as well. Okay, so we can note that update from Pam, and that takes us on to item number 3. So this is our integrated performance and quality report. As has now become tradition, I'm going to hand over the chair at this point to David, who will expertly take us through the vast amount of data that we have in our report, and then we can do questions as well. So David, I will hand over to you.
Thanks, Sarah, and good morning, everyone. I suppose while resources are going to dominate a lot of our discussions during this year, it's important not to forget why we're here. And the performance and quality report reminds us of what services we are here to deliver and for the patients that we care for. The report is in our combined papers between pages 183 and 216 for your review. And just a reminder, particularly for those new colleagues who've joined us on the board, the IPQR goes through the various committees of the board. That's Finance, Resources and Performance Committee, Clinical Governance, Staff Governance, as well as through our HSCPs in terms of review. So what comes to the board today has already gone through those levels of review. You may well have seen them as you participate in those other governance areas, but this is probably the first time you'll see it as it comes together as a whole. You'll see in page 188 is an overall summary of some of the key metrics, particularly those that are reported nationally. And again, the performance is reviewed between what we had in our annual delivery plan, or ADP, as well as what our national targets and shows you our performance against each of these. Just a couple of highlights for you before I open up to questions. In pages 189 to 191, you'll see the public health and prevention section. Pam was talking about vaccination as being a key element of prevention. Tim would often remind us of that. And you'll see the updates with regard to both flu and COVID vaccines. I suppose just in a personal observation, you'll see that the uptake, both locally as well as nationally, is relatively low, despite all the attention that we've got nationally around COVID inquiries and such like. It's probably disappointing to see that the uptake around prevention and vaccination has dropped so much, but that so I suppose in all our opportunities in interacting with the public, reminding them of that key element of prevention is going to be important for us. Pages 192 and 193 looks at our children's services. Our performance around CAMS is still showing, I would say, moderate progress with some variation that's generally in the right direction, but still more work to do. In NDAS and our neurodevelopmental area, we recognise that we've been looking at that over a period of time. We described, and I think we had an update the last time, it's a fairly complex area involving multiple different disciplines, as well as working with Highland Council and the education department within it. So meetings continue with them on how we can manage both the demand as well as the pathways of assessment for those individuals that would be referred through the service at the moment. Unscheduled care in 194 to 195. It's still a very challenging area that is very live in our both our acute hospitals as well as in our communities. And we referred to those patients whose discharge has been delayed. That still remains a high number, and reflects the capacity challenges that we have within social care itself. 196 to 203 looks at scheduled care, and TTG performance is relatively good. Performance and activity has increased, but perhaps slightly masked by our outpatients performance, and perhaps there's latent demand still to come through for outpatients that will put further pressure on TTG, but that is the balance of that is still being managed. I think that's not just a local challenge, but a national challenge, and it's a similar picture across the country. Pages 202 and 203 reflect our cancer performance. You'll see a drop in cancer performance, and after I finish these opening remarks, I'll maybe invite Catherine just to make a few comments around that. I'm sure that will be of interest to you. And then finally, sections 207, pages 207 to 213 looks at complaints. There's some additional analysis in there for you. You'll see that we've had an impact in terms of complaints related to the interruption in our oncology service that was resumed in that more regional and national way that we've been describing. And our thanks to the boards and clinicians who are supporting us in that service. There's also some reports around the quality assurance associated with handling the complaints, as well as those referred to us from the SPSO. Also, you'll see finally a section related to falls, and we're seeing signs of improvement in falls, which is of good news to us. So with that, I'm going to maybe invite Catherine to say a few comments around cancer, and then we'll open it up to questions. And then my other executive colleagues on the call will help us address those. Thank you. Catherine.
Thanks, David. And obviously, we've done some analysis and review of that dip in performance and trying to understand the reasons behind that. The majority of that relates to diagnostic pathways in the early part of the pathways, and we have had some challenges in terms of capacity, both for MRI access to meet that part of the pathway timeframe, and also in our breast service for access to imaging and radiology. We've been supported from NHS Lothian and reached out to see if we could get capacity to come in to support that. And we believe that those areas are going to recover over the coming couple of months. I think it's fair to say that cancer performance is a challenge nationally, not just within Highland, and some of our issues relate to the vulnerability of our clinical service position, and we know that Lorraine is doing work on that, and that's been recognised nationally. As a result of the concerns around cancer performance generally across Scotland, there has been a Cancer Performance Delivery Board established. I'm a member of that. Boyd is also a member of that national board. And there's recognition, certainly in the first meeting that is chaired by the Chief Exec of NHS Lothian, that our approach in terms of detecting cancer early and pushing early detection is perhaps having some unintended consequences. So we're going to be examining across all health boards the conversion rate to positive cancers, because whilst we have done well in terms of bringing people forward that may be suspected of cancer, what that's doing is increasing the volume of referrals in. And that is, there's a fine balance to be struck in that in terms of the capacity to manage all of that. And some of that is leading to some of the delay in our pathways. So a lot more to come in terms of cancer. It is a very complex subject area, as I'm sure you can understand, and more than happy to come back with more detail at any point, Chair, should that be required. Thank you, David.
Thanks, Catherine. Okay, I'm happy to open it up to questions from colleagues if you have them. Alistair, can I come to you first, please?
Yes, thank you. And the comments that I was going to make some of them under reporting back on the minutes of the Clinical Governance Committee. So rather than take up time twice, I'll just make the comments I was going to make then now, Sarah, if that's okay. I think this report is in terms of format is really useful. I think it gives us a lot of the information that we need in an easy, digestible way. The summary sheet is excellent, David. It's just a pity there's so much red on it. Perhaps if it would be even better if it, I think that summary sheet makes everything stand out, because if you look at the balance between the red, the amber and the green, it actually shows the challenges we've got. I think NDAS is an area that the Clinical Governance Committee has taken a keen interest in, is concerned about. Had a verbal update at our last meeting. Is going to written SBAR coming to the next meeting on that, and I think it's an area that we need to collectively across the organisation really understand what's happening there with our partnership with NHS Highland, the referral routes, the training, and all the interactions that are taking place on that. I think cancer to me is keen interest, but I think we need to, and I think we're right for Catherine to focus the time this morning on that, because everybody knows somebody that's impacted by cancer. Nearly every family is touched by someone's got cancer, and in Highlands it's a small community that people are, and Argyll Bute as well, people are impacted by it. I think we understand part of the reason for it. I think the additional information was useful this morning. But I suppose the real question, Catherine, is when can we see a return to some of the excellent results that we had previously? What is the seismic change that has caused the slight downturn in performance in the 31-day target, but more concerned is probably the 62-day target. What else could we be doing as a board to try to address that? And I think one of the things about the fragility of the services, which was mentioned in Pam's update report and was touched on by Lorraine as well, in terms of vascular, I think we've got a number of areas across the service where we are impacted by difficulty in recruitment and retention of staff. And I actually wonder, David, if it'd be useful having some sort of traffic light system on each of these slides in the future that actually indicates, if you like, taking the temperature of the staffing situation. You know, have we got vacancies? Are we finding it difficult to recruit to, or is everything fully operationally staffed? I think it might just help flag up, and it might reduce the need to repeat the narrative so often of recruitment and retention, and allow focus on something else. I think overall there's a lot to take, and I suppose it's natural that we tend to focus on the areas that we want to see improved when other areas are doing well. So there is obviously some very good success stories within this, but there's also some areas we need to home in and focus in on. And I think really the cancer one to me is one of the big ticket items on this. Thank you.
Thanks, Alistair. I think the other element related to cancer services is the volume piece that Catherine mentioned, where the capacity is limited within those services, and when the referral levels increase, then that immediately has the impact on the ability to absorb that demand, and it will cause that level of variation. And I think that's why the national discussions are going to be so important, so that we can look at this as a whole to say, have we got the screening right, and how we manage that. In terms of the vulnerable services that you mentioned, that is part of a national exercise that's going on just now. I know Lorraine is directly involved in that. So it may well be that we're able to bring a paper forward in due course once that work starts to progress in terms of what that's going to mean as an overall point of view. But I certainly will take your suggestion on how we might be able to flag that going forward in terms of those vulnerable services. The one thing I would say is that particularly around many of our services and demand, we are always going to be constrained with resources to some degree as to whether that's vulnerable or not. But I do take your point, and we'll give consideration how we might be able to display that. So thank you for your comments. Sarah, can I come to you, please?
Thanks. I'll keep it brief. I can see lots of people want to ask questions. It was just around those vaccine uptakes, and I suppose reflecting on our earlier conversation about population health and prevention, and using the public pound to deliver the kind of most effect, thinking about that vaccination uptake, and this might have to be taken away to come back, but I'm particularly interested in how we're doing in terms of staff uptake of vaccines, and how that compares to how it's been previously, and where we are around that. So, and I don't know, we might not have that data here with us today, so I'm happy if that can come back, or Tim might want to come in. And I suppose just the other observation, that executive summary sheet, I think Alistair's right, there's red on it, but there are some blues and greens as well. And I suppose when I was looking at that sheet, it reflected to me the complexity, and there's some areas where we do exceedingly well, and other areas where we're clearly struggling, and demand is outstripping our current capacity, and where we need to realign that. I just also wanted to reflect that we do have some great public health and population health data in our IPQR, but that summary sheet really focuses on the other end of the scale, and I wonder, as we kind of try to shift that balance, and that where we're investing, where we're focusing on, and that prevention and population health, if we want to think about that in our display. But yeah, so that the vaccination question, actually, if that's okay.
Thanks, Sarah, and I think that's a really interesting observation in terms of that summary sheet, so happy to take that away. But maybe if I can invite Tim just to respond on the vaccination uptake.
Yeah, thanks very much, and thanks, Chair, for the question. Specifically regarding your question on staff vaccination, there are two particular elements to it. Staff uptake is, unfortunately I haven't got the figures exactly to hand, but our staff uptake is higher than the national average, so we're proportionately better than we are overall on staff vaccination, both for health and social care. The statistics for COVID are on frontline healthcare staff and for flu on all healthcare staff. While we are better than the national average, the figures are still low. So our uptake for COVID vaccination frontline healthcare staff is somewhere in the region of 30%, and for flu for all healthcare staff is somewhere, I think, just shy of 50. So that's several percent, I think, higher than the national average. So certainly we're a better board when it comes to that. But it demonstrates some of the challenges in getting staff in vaccination in general. So there are local issues and we need to address those, but there are also national issues, and the staff vaccination tends to have fallen down a little bit. One other good thing to say about vaccination is that our concentration on the most vulnerable is still relatively good. And we have a couple of percent higher than average uptake for care home residents. So there are some good points regarding vaccination, but overall there's both a need for a national improvement and also concentration on local improvement, and we're working both with Scottish Government and with Public Health Scotland to look at how we can improve vaccination, and we're the first board that the new Public Health Scotland team are working with to see what we can do to get a more efficient and effective system and to improve our uptake.
Thanks, Tim. Gareth, I see you've put your hand up. Did you want to come in on this point? Was that what you were? No, okay. Okay, I see a number of hands. I'll maybe take two folks at a time. So if I can come to Bert and Joanne, and then we'll go to see if we can answer and then move on. Bert.
Thank you, David. A couple of observations and a couple of questions. Firstly, I really like the format of this report. It has evolved and developed over a period of time, and the continued improvement that you're making, for example, in the additional analysis that's been provided, for example, in complaint activity, I think is an example of that. I'm pleased to see the steady improvement in statutory and mandatory training. I appreciate that it's levelled off a wee bit, but this is something that we've given a lot of focus and attention to over a period of time. There's been a lot of effort gone into this, and I think it's really encouraging to see that improvement that has been made. As the narrative says there's still a bit of work to be done in relation to appraisals, which is a really important part of work, of course. And I hope that the actions that are being taken from this month onward will lead to the improvement that we've seen, for example, in Statman. But well done overall there. In relation to complaint activity, factors which have influenced performance, that it's good to get an explanation about that. I appreciate getting that information. And the factors which have influenced complaint volumes, I was interested to read there about dental related complaints. Now, given I'm not in a committee where that has featured, I wondered if we could just hear a little bit more about that comment, please. Thank you.
Thanks, Bert. And Joanne, can I come to you for your question, please?
Thanks, David. Some of my points have been covered because I had extra questions about cancer and vaccination. So thanks, Catherine and Tim. Catherine, one for you. Page 193, the NDAS report. It talks about, it's a question around timescales. I understand that there's an SBAR coming to the next clinical governance meeting, but in the timescale it says at pace. And I just wondered if you could clarify exactly what you mean by that, because I I'd probably like a bit more definitive timelines than at pace for the report. And moving on to pages 211 and 212 in Louise's report, the performance overview boxes are blank, and I'm just wondering if somebody could clarify whether there's no data, or why there's nothing in the boxes on the right hand side, or do they not apply and they shouldn't be there? Thank you.
Thanks, Joanne. You've got some folks scrambling for that particular one, but let me come to Boyd if I can around dental. No doubt that was part of the discussion within clinical governance, but Boyd, could you want to pick that one up, please?
Yeah, I'm not able to identify the specifics of complaints, but we see variation in complaints. And if you take dentistry as an example, when something happens, so for instance, where there's a local problem in an independent practice, we might still receive complaints about that service in terms of people's ability to find an NHS service, which can happen where independent practitioners reduce their NHS contribution and do more private work. We also can get complaints about, for instance, out of hours access. And again, this applies more to people who have not registered with a dentist or have had difficulty in achieving registration. What we're seeing is consistent with national patterns, and with the eye on the whole of Scotland, I know that there is a second paper being written as we speak to take into the national forum about the shape of dentistry in 24 and going forward, as there are nationally challenges around recruitment of dentists right across the country, with some variation geographically within boards and between boards. And we also have some of these local variations. For us and our population, it's probably a greater challenge, as always, with delivery of these kinds of services when you're in a more remote or rural part of the Highlands, because there isn't much choice. If there's a problem with your nearest dental service, it could be quite a long way to the next one. The Health Board very often receives information, including complaints about some of these local issues, even where we're not always in absolute direct charge of the service, but rather commission it through an independent practitioner. Is the usual way that services are run. Finally, we have got the public dental service, and we also have specialist dental services. Occasionally there may be complaints that arise through these, but the commonest source is to do with community access to general dental care.
Thanks, Boyd. Catherine, around NDAS timing around that, what's your view of that?
So we've had a very good engagement exercise in December. That was with key partners. So we had obviously Children's Health Service from Highland Council, but we also had education partners in the room, and that was a significant step forward for us in terms of that multi-agency approach that needs to be taken to support getting to a different place in terms of the NDAS waiting list. We have had commitment from education, and they really want to step into this in terms of NDAS and are committed to working with us to review all of our referrals that sit on the waiting list and take a slightly different approach, recognising that perhaps not all of what is sitting on the NDAS waiting list needs the high-end requirement of the core NDAS service. In terms of what does that pace mean, Joanne, I believe that means within the next couple of months we will be formulated in terms of understanding exactly what the impact of the action that our education partners are offering us will have on the waiting list. I think there's a significant number of children that are on that waiting list, as you're aware, and it's going to take some time to work through all of that and get to everybody on it. So until we've done the work with Highland Council, I can't give a total commitment to exactly what those timeframes will look like. But what I can commit to is coming back in much more detail over the next 4 to 6 weeks and being able to give a commitment then once we understand what the art of the possible is, with our education colleagues who are absolutely committed and very supported to working in this area with us. Thank you.
Thanks, Catherine. And just finally, a question around the formatting around the pages. It just reminds us that our report is not absolutely perfect, Joanne. So we were having a discussion about how we might reflect, because we were trying to reflect both the national position and the wider position. Not everything that we're reporting through our IPQR necessarily has those in terms of national standards. So that's been left there in error. We will look to see if we can develop something in that line. And if not, we'll take that box out. So apologies for any confusion that was caused. Okay, if I come to Alex and then Susan.
Thanks, David, and well spotted, Joanne. I missed that, I must admit. So that was a good spot. Couple of questions. First of all, I'd like to echo Alison and Bert's comments about the actual format. I think it's improved. It's very good. It's very useful, and it's very visual, which helps. Couple of questions. One for Catherine and then one for Gareth. Catherine, on the outpatients waiting time, we've got predicted to be just about 3,000. Probably over 3,000 patients that won't have seen or got an appointment within a year. Have we got any that slipped back into 2 years now? I know there was a big push last year to try to get away from the 2-year bit, but because of the relatively sharp increase, when you look at the trend, it's going up fairly quickly. Have we got any that slipped back into that 2-year bit? And then for Gareth, I'm not as kind as Bert. I think the training numbers are not good at all. When you look at it, the appraisal completion rate is flat. The training numbers are flat over the year, and where mandatory e-learning has gone up by about 7% over the year, which I would have expected to have been a little bit better than that. So I know you're saying that there's going to be more focus in the year, but what exactly are we going to be doing to get it up from under 30%? Or should I say, and I'll turn this round, you've got 73% who haven't done an appraisal, and that's not good. So can we get a bit more focus on that? Thanks.
Thanks, Alex, for your questions, and we'll come back to you in a second. Susan, if I can come to you for your questions.
Thank you, David. And I wanted to just say how much I appreciated and supported your opening comment about how, despite our really difficult financial situation, we still have the service to run, and we need to focus on that, and we need to give attention to it. So thank you for bringing that out. Excuse me. My question is also perhaps for Gareth. It's a workforce issue, and I was looking at the times it's taken us to fill our vacancies and how there's been a big uptick in November. I wondered if that's an artifact of the fact there are nearly 2,000 people in the system, according to the notes, and has it improved since then? But obviously, you know, optimizing our workforce is really crucial for us to be able to deliver what we need to do. So could you say something about that? Thank you.
Thanks. Catherine, I'll come to you first on outpatients, and then Gareth, I'll come to you both on the training as well as the vacancies if I can. Thanks.
Thanks. In terms of do we have any patients waiting longer than 2 years, it's my understanding at my last review that there were no patients waiting longer than 2 years. We do have many patients that are tripping over the 12-month period, and we can see that on the waiting list. That's largely because we've been focusing on the tail of the waiting lists, and we continue to do that across all areas. So hopefully that answers that question. Thanks, David.
Thanks. It is a good question, and it might be something we look at as we form our next report that will go through FRP, just so that we can capture those long waits, because that still remains a focus as well as the aggregated number. So thanks for raising the question, Susan.
And just one more point on that, David. I wouldn't expect that we have any patients that are waiting on the waiting list that are over 2 years that haven't been offered an appointment, but sometimes there are some people that we can't get in to service and they don't get taken off the waiting list. They will remain on under the waiting times guidance.
Yeah, that's a good point to make, Catherine. Thank you. Gareth, can I come to you with regard to training and vacancies, please?
Yeah, so in terms of the training points, I agree with the points made, and we've taken a paper through executive directors group within the last week or so around an improvement plan in relation to appraisal rates and the PDP completion during the year. So the proposal will progress to the area partnership forum for discussion and staff governance, so it will flow back through to the board. But the main premise of that is to focus on our management over the coming year in a phased approach to make sure that all our managers complete one. And we'll start with a senior management structure first and flow down through. I think that in focusing on the managers first, that should hopefully then ripple out into the staff that they manage. But yes, it does need more focus, and I have been mentioning that and training that in conversations in other committees for a period of time. So it's our next area of starting to mobilise focus on these things. Managers have many things to focus on, but this absolutely has to be something that is core to what we do. In terms of the statutory manager training, that has been the Short Life Working Group has been meeting. We are then launching next month, this 1st February, the revised suite of reporting, which will focus very much on, that will go to the executive directors, which will be presented to all managers, and it'll bring a bit more visibility. We have a series of self-service dashboards, which are great if you're proactive in going looking at them. But there's an element of being a bit more upfront with what goes in front of senior management teams and provides a bit of focus around that. It is probably worth noting that the e-learning completion rate is hovering around about 70%. So the way we display this sometimes doesn't necessarily give us a good picture, and that 70% is still shy of where we need to be. Another conversation we're having is whether the target is set at the right level. Certainly where I was previously, the target was 80%. I'm not saying it right, it's for further discussion, 80%, and that was based on factors in terms of availability of staff and so on. It's based on figures. So we're going to do a bit of a review of that, because we won't change that target without a further discussion with colleagues, but we're looking at the moment. But still got another 10% to go, so it's still work to be done. The practical training is another element that we need to sort of focus in on and work, and one aspect of that is space. And availability of space and the geography, etc. So not without its challenges, but absolutely has to remain a focus of what we do. So I completely agree. But hopefully that gives some assurance we are continuing to focus on it as a board. And my colleagues will be supporting on this because it's a responsibility across the executive team and senior management team. In terms of the recruitment question, again, I think the way we've presented the data is it's between 120 and 125 days, so fluctuating between that over the last year. I think the challenge we know we face is overall that average is not where it needs to be, and it needs to be lower. So we have an improvement project underway looking at that. So and again, continuing to look at that. The aspects of how the service works are that there's an element of self-service to that. This is that recruiting managers need to undertake aspects of the process, and we do find that that's why some of the delays lie, and particularly outliers tend to be where that lies. There are delays within the recruitment team. We recognise that as well on occasion. So it is a combined shared responsibility between our recruitment team and hiring managers. So there could be a hypothesis that during those periods of times where it goes up, maybe where there's pressure in the service, which is generally what gets in the way of the activities like shortlisting, completing interviewing notes, following the process through. So that may be the correlation. It's probably more likely service pressure that's going to be resulting in the delays to the process, although volumes of activity may relate to that. But they stayed pretty steady in terms of the number of vacancies going through over the course of the last year. So hopefully that gives you a bit more information on that point.
Thanks, Gareth. Hopefully that's been a helpful update. Okay, let me come to Jerry, then Karen.
Thank you, David. Yeah, and just to echo colleagues' comments on the format and content, I think it continues to get better almost every time we see it. I think I've probably got a couple of observations rather than questions, David, because lots of my actually specific questions have been picked up. I would agree entirely with Sarah, and I was going to make the comment myself in terms of the executive summary. We have to be careful the executive summary doesn't just become the report, but it is terribly treatment focused rather than looking at the whole health and care and prevention system. So I think something in there. But the main observation I wanted to make was related to and like Pam, I don't like using the term the delayed discharges on page 195 for colleagues to look at. I'll use the words in there because it's benchmarking. We're the worst performing board in Scotland when you look at the number of delayed discharges per 100,000, which is not a metric I especially ascribe to, but it's there. But I'm not looking at this from a performance point of view. I think to me it's following up a point that Pam made in her update to us. It to me is a clear indicator of we've got an integrated health and care system that's just not working at the moment, and we really need to devote a lot of focus into how we actually change that in there. I'm fortunate enough through the Health and Social Care Committee to get more detail behind of this, and we know lots of the drivers are our care homes and particularly our care at home unmet need, which is actually quite big there. And it's maybe something we need to think about expanding this on. But again, I'll go back to my previous comment in there. But I really do think in terms of how we move forward as a health and care system, we really need to be focusing a lot of our time, a lot of our resources into addressing this problem, these issues that are in there. Not from the point of view of, oh, look, we have got a number of delayed discharges, but actually we've clearly got an integrated health and care system that's not operating as we would like it to work at the moment. Thank you, David.
Thanks, Jerry. That's helpful comments. Karen, can I come to you?
Yeah, thank you, David. It's back to appraisals for me. And really just for my understanding, I would be interested to know the appraisal rates per employee group and to see if there are any areas of particular concern across different employee groups. I'm also interested how that sits with the numbers of employees that we have who are registered professionals, because the best practice is that an appraisal sits alongside a registration approach. So I would again be interested in a bit more detail around that and any future information that's going to come forward to the board. Thank you.
Thanks, Karen, for your question. Gareth, can I come back to you on that one, and then I'll
yeah, I suppose we just need to think about what we take through the Staff Governance Committee, and maybe that's a conversation could be better to pick up the Staff Governance Committee in terms of what we scrutinise within the committee. Certainly, we can cut information in different ways, but certainly happy to have a further discussion with colleagues in Staff Governance as well.
Thanks, Gareth. I think that'd be helpful just to be able to add that. And Jerry, I welcome your comments regarding those patients who are delayed to discharge. It certainly will require us to try to change the way that we manage risk at the moment. And obviously, every time you make changes, that introduces other risk. And sometimes we can get stuck a little bit, and sometimes I think that's maybe part of our reflection of where we are. Is certainly the external factors related to managing social care are significant, and it's going to be very much an integrated response, which is maybe an overused word, but between members of the public, our services, and the voluntary services, and what local communities are able to do to support people. And it will require a change in that regard, or else we'll be left with a similar challenge on an ongoing basis. The one thing I would just remind us that while the overall volume of those people in that category remain the same, there are it's not the same people who are remaining in hospital over that period of time. There are certainly some who will be there for a period of time, but there's also a turnover of patients too. Okay, Emily, can I come to you finally? I think you've got the last question for today.
Thanks, David. I just wanted to echo the comments from others about the report format. I find it really useful, particularly having come into it as a relative newbie. Particularly the trend information and the benchmarking versus other boards is really, really helpful context. So thank you for that. I have hopefully a relatively straightforward question. Just as we're looking for, in some areas, quite a significant improvement against the backdrop of really big financial and resourcing challenges, I don't underestimate the scale of that challenge. And I wondered in that context if there's been any thought given to setting interim targets just as stepping stones towards some of the sort of bigger gulfs between the national target and the current position. And I guess particularly in relation to treatment times, that stood out for me that actually it's a really long way that we've got to go. So are we looking at interim milestones that we could be reaching, apart from anything else, to keep people motivated and to recognise where progress is being made? Because I think if it looks like we need to make a 45% jump in some of these measures, it's quite a mountain to climb, and that's going to take a while. So are we looking at interim measures and how we could recognise progress sort of on a shorter time scale?
No, it's a very pertinent question, and Emily, because we're in the process now of starting to formulate our annual delivery plan, which very often is our commitment to government in relation to what we intend and what plans that we are setting out to do. And you'll notice even in this year that what we committed to do was not necessarily meeting the national targets. So that's why we report our performance against both of these things. Secondly, then within the year, we can have shifting sands and shifting priorities, which has also affected some of our capacity. As to whether nationally they will be looking at some of those targets, I would expect they're going to have to, given the level of constraints. But obviously that becomes very political. So it'd be difficult for me to double guess what they will do there. But certainly as a board, what we'll do is make sure that we are clear what we believe we can and should set out to deliver. That's it's set as a bit of a negotiation with government, and that will fall into that wider discussion that Pam alluded to at the beginning of our session today. So there's a lot more to come in that, but I think your comments are absolutely spot on. It's important that we have targets that we are planning on delivering and aim to deliver. Whether that meets the aspiration of the population or indeed the government, that's a secondary question, and it's also useful to track both of these things together. Lorraine, did you want to come in and add anything to those comments?
Yeah, just 2 points. I think that the comments are well made about the executive summary, and they're mainly focused on health. They are reviewing the local delivery plan at the moment, which you'll remember we brought in all the metrics into the IPQR for. So I would hope that we would be able to start reflecting that as we develop our ADP and look at, for example, Tim, you've got the ABIs in there. What is the national target and how does that reflect with benchmarking? So it is very high in my mind. Also incorporating what are our key metrics for each of our well themes within our strategy, and they have to be reflected too. Emily, your question's really pertinent. I mean, we're embarking at the moment on, I guess, service planning to align that with our ADP, and that really is looking at what is our workforce capacity that we've got, what is our financial envelope, and what can we deliver to ensure that quality and safety of care within all of those metrics. So we hope to be able to provide, I guess, a more accurate reflection of what we will be able to deliver, and also think about a risk-based decision approach to that as we move into making that trajectories and targets. Thank you.
Thanks, Lorraine. Thanks for your question, Emily. Okay, I think it's going to be the last two questions. Muriel, then Alex, and then we'll probably need to draw this section to a close, I think. Sorry, Chair.
Thank you. It's for Louise. It's the thank you, Louise, for the way it's presented. It's the infection control stats. They seem to be on an increase, and I'm wondering what the impact is on service delivery and treatment and diagnostics delays and costs involved with that, and part of the improvement plan going forward.
Okay, thanks, Bruno. I'll come to Louise in a second. Alex?
Yeah, thanks, David. No, it's not a comment, it's more an observation going back to patients being delayed in discharge after what Jerry was saying. And when you actually look at the benchmarking, if you compare us to the boards with comparable populations, then we are considerably worse, in some cases twice, some almost 3 times in one particular one. I'm just wondering how much of that is to do with our remote and rural, although some of those have also got remote and rural. But the other one is they're an IJB and we're not. Is there an issue there that we need to consider as well? Thanks.
Okay, if I take that question first and then I'll come to Louise. I don't think there's a definitive answer to that, but these are exactly the questions that we're asking. I don't believe it's just based on structure, but what is not necessarily explained in the metrics is the capacity that is available to boards. So whether the population is the same size, the amount of provision that you have in those respective areas will dictate as to whether, it's got a lot to do with performance. Not completely, but it's a lot to do with it. But I know that Pam and the team are looking at other boards, other partnerships as to what they do and how they perform, as to when we get to changing what maybe our risk profile might be or how we are meeting the demand. Whether there are different opportunities and different approaches that we may take that may improve things. But there is undoubtedly a local element to that as to what resources are available within localities, which has got both capacity as well as financial pressures in that regard. Louise, sorry, can I come to you finally? Fiona, do you want to come in on that point? And before we move to Louise, sorry, Louise.
Yes, if you don't mind, thank you. I think probably it's only fair as well to reflect that whilst that headline figure for the delayed discharges is a board-wide figure, that the proportion across the 2 areas is quite different, and that the overall performance between Argyll and Bute and Highland in relation to delayed discharges is quite starkly different. Now, again, like David, I would caution making a cause and effect link between model and outcomes. But I think there are aspects of the way that we've organised our in-house as well as our commissioning approach, our strategy in Argyll and Bute that have been particularly supportive to the delivery of a better performance in relation to being able to treat people closer to home and bring them out of hospital expediently. That I think it's fair to my team that we should reflect that as a positive. And I think that there's aspects of that it would be useful to consider as I come into my new role that could be helpful in a Highland context. They are both remote and rural contexts, but again, the services are configured quite differently, and delayed discharges aren't just about one factor or another factor. They're about the way the whole system operates. So I think that these are interesting points for us to consider. I think there are strengths and weaknesses of the different models. But whether there's more that we can do within the lead agency to look at how we commission and how we ensure that we understand population need and then reflect that in the services that we provide and commission, I think that's a bigger debate for another day. But I just wanted to draw that out as because I think my team do need to be commended for the work that they do in relation to the delayed discharge position in Argyll and Bute. Thank you.
Thanks, Fiona. That's very helpful. Louise, can I come to you with regard to Muriel's question around infection control?
You can indeed, and I suppose when you look at the stats, there's some areas of infection control that aren't significantly different this year. So if you look, there's always peaks and troughs between the different times of the year, and we've gone up and down in a fairly regular pattern. However, there are some areas that have got a slight increase in trend, particularly around C. diff. So you're absolutely right. There are things that we need to look at from that increasing trend, but we also need to look at the norm anyway. And the question about impact, yes, absolutely, it does have an impact, in particular in the acute hospitals, but not exclusively, obviously, where wards have to be closed, or we have staff pressures because staff are off too, and obviously the impact on people, the people that are experiencing those health problems and the knock-on effects for their physical health. So there's numerous different concurrent factors that make this a challenge and something that we've got to try and work through. And the team certainly are very proactive in being very actively engaged in any and all patients that are unwell and any outbreaks, etc. But there's also the proactive work that we need to do to avoid to do the reduction and the avoidance where humanly possible. That includes making sure that the training that we're increasing our training rates, we're increasing our visibility. And the team are also looking at how we reconfigure for the future to provide a bit more sustainability in line with what we used to in COVID. We had some additional infection control resource that gave us the opportunity to spread the team over the 7 days and have much more flexibility of how they worked with areas. We've had to reduce that back to the funding levels that we have. However, the team are going to reconfigure as there's some changes going on in the team in terms of personnel. We're going to be reconfiguring so that we can provide that proactive 7-day support.
Thanks, Louise. Before I hand back to Sarah, just to say thank you for all your questions and comments this morning. In terms of the report and its formatting, I'm sure Lorraine will feed that back to her team in terms of the work they do around that. So thank you again, as well as some helpful suggestions how we might even make further improvements. Your questions are really helpful because they test us to make sure we're looking at things in the right way, and are often insightful questions to us. So please keep them up. The other thing I would say is if you have questions as they're going through the various subcommittees or even in between, please feel free to reach out to us if you would like to do that. Either Lorraine or I, you can channel the questions through and we'll be happy to try and get answers to things that crop up. But again, thanks once again, and I'll hand back to Sarah.
Thank you so much, David. Expertly done, as always. That is no mean feat, coordinating all of that. And just to echo some of David's comments, I'm really pleased to see the level of engagement around our IPQR. I know this is not the only place we scrutinise this data. As David said, it happens at our various committees and subcommittees and so forth, but it's really good to see that engagement. And I think actually that reflects the level of work that we've done as a board to consider what data we look at and where and when and how and why, and importantly the so what. And I think it would be fair to say that the IPQR will be constantly evolving, as it should, to reflect the areas that we need to focus on and scrutinise. But I would just like to say a huge thank you to all of the team, the senior team, but I know you've got loads of people sitting behind the scenes that put a lot of work into pulling this together as well. So a really big thank you, because I think this has come along leaps and bounds for us as a board, and it's really helpful. So thank you, everyone. We're behind schedule, but that was a really good conversation, so I'm not too upset about it. We are going to move on now to item 4. So we'll do item 4 and then we'll take a break after item 4. So I will hand over to Heleth, and sorry, just 2 seconds, because of course my computer is just having a little moment. Got too used to relaxing while David was taking over there. So Heleth is going to talk to the next report, which is our finance assurance report for month 8. So Heleth, I will hand over to you.
Thank you, Sarah. So the paper presents the November financial position, which highlights that the board is forecast to overspend by 55.975 million. That's just above the plan of 55.8, which is the minimum that's expected by Scottish Government. The month 9 position is actually indicating that our forecast is set to reduce a little, and we're showing a slight improvement. So we'll be reporting that through our next Finance Performance Committee. The first graph on page 14 of the papers you'll see has been updated to show our current position against the initial and the revised plan. So hopefully that gives a clearer picture. As you can see, the run rate is above the planned position, but the recovery plan that we've previously shared will bring this back in line for the end of the year. The key areas to highlight for this year are that the partnership and the Highland Partnership and acute expenditure has deteriorated, while we've seen a month-on-month improvement to the forecast for the support services and Argyll and Bute. We're still anticipating additional allocations of 83 million, and our savings are forecast to deliver 15.73 million of reductions, which has, again, it's deteriorated month on month. We're just not seeing the planned reductions coming through at the level that we were hoping. So we are seeing a significant reduction in the supplementary staffing, which is one of the key areas we were looking at for our savings. But as I said, they're just not quite coming through at the levels due to the demand that we've also been experiencing. On page 28, we've provided some detail there of total spend by subjective. So as you can see, about half of our expenditure is on pay. Page 30 highlights some of the improvement work that we're engaged in nationally, and also just to highlight that we have put in place some non-pay controls across the organisation within the procurement team. And given that we're now at the end of January, I think the likelihood of some of our risks materialising now are much reduced. So we are confident that we will be achieving and hopefully improving on our current forecast. So just moving on to capital, we are continuing to spend in line with our current plan, albeit that is subject to the budget announcement, which Pam alluded to. I will move on to the budget assumptions then. We have submitted our first draft, our high-level draft of the financial plan yesterday. So I can give some very high-level figures, but as I said, at this time, this is the draft and it's the first iteration. But the budget announcement did highlight an increase to the NHS budget of 4.3%. Compared to our 23-24 budget, but this relates to the pay uplift that's awarded for 23-24. So in actual fact, the budget for next year is a 0% uplift, so we are on flat cash for 24-25. We have previously set out for the 23-24 budget, we highlighted that the financial gap between underlying expenditure and our allocation was around 100 million of deficit. So our position this year of 56 million is due to additional allocations we've had, some of those non-recurrent, under the non-recurrent actions to bring us down to that lower position. So obviously with coming into 24-25 with additionally inflationary pressures and contract uplifts, we have submitted a draft plan with an opening position of 121 million deficit, and that includes 24 million for adult social care as the lead agency provider in the north. We do have some brokerage assumptions that we've been provided by government around the maximum position that we can be at this year. And the impact of that is the scale of challenge that we've had, as Pam mentioned, whereas previously we had assumption of 3 to 5 years to bring us into financial balance. That first year plan has significantly changed due to that assumption. The Directors of Finance are working closely both nationally and across the north of Scotland. We're trying to identify options and choices that we need to progress. We are looking at those as in 3 different categories as to whether they need support and guidance from Scottish Government, whether they are things that we can agree nationally as boards that we consider and implement, and have a once for Scotland approach to that. And then we'll have our own local choices that are unique to us in the Highlands. And then obviously, as Pam has also indicated, the capital position is to assume that there are no developments, and we have been asked to pause all developments as we stand in this financial year as well, but take into account any contractual commitments. So that does mean that we have been able to bring our capital plans to a natural pause, with the two bigger plans will be ceasing at Reba Stage 2, which is where our contractual commitment ends, and that takes us to the end of this financial year. I will open for questions at that point, recognising that that figure for next year is a significant figure, and that's something that we're going to have to work through around the choices and the options over the coming months in time to submit our final plan in March. I'm happy to take any questions. Thank you.
Thank you, Heleth. So in some ways, we have been talking about the financial challenge for a long time, and that's no surprise. But I suppose this really brings it into focus and is perhaps more stark than it had been before the budget announcement. So realise people will be processing that, and obviously we had the opportunity to look at this over the last few weeks just to wrap our heads around it, and I know that Heleth and your team have been kind of working through the detail of some of that, so that we can be clear on, as Pam said quite rightly earlier on, the choices that will have to be made, and how we do that. I'll open up for questions, comments. I recognise this gets scrutinised a lot at our FRP meetings that we're having very frequently, but this is a really good opportunity for other members to ask questions and perhaps just to go over some of the areas that we might have talked about at FRP a little bit for the benefit of the wider board as well. Graham, I'll bring you in, please.
Thanks. Heleth, a follow-on question from one of Pam's comments earlier about trying to get a better understanding of the cost of delivery in remote and rural areas. And I'm just interested in what that kind of process is, and because I understand it will be very, very complex to do and to get a real understanding, but I'm just wondering what the kind of plans for that understanding are. Thank you.
Thank you, Graham. I'm not sure that there is a specific plan at the moment. I have put a request into the Scottish Government Finance team just around some benchmarking data, so to try and enable us to see how we deliver our services compared to other boards, and hopefully that might give us some comparative data on a population basis and on a geography basis. I've not received that back yet, so I don't know what that looks like, but that's the way I'm trying to approach it, to see where we deliver and how we deliver our services, the number of estates we have in order to deliver services, and how that compares, as I said, from a land mass perspective, but from also a population base perspective, to see whether that gives some indication around different board sizes and geographies, and whether that starts to give us a bit of that picture.
Thanks, Helen.
Thanks, Graham. Alex, I'll bring you in now, please.
Yeah, thanks. There's questions coming from the FRP, but not directly. Anyway, I think this question is probably more for Richard than for Helen. But in terms of the stop on the capital spend that we've been instructed to do, have we got a feel for any penalties that we may suffer, and how much that will be, particularly on the bigger projects? I'm not talking about the ones where we're carrying on with the construction, but things like the Caithness redesign and Lochaber in particular. And then the second question is, in the letter that we got, it asked us to focus on backlog maintenance and spending on that. Have you got enough money, Richard, to do the backlog maintenance, or are we still going to be considerably short in terms of budget? Thanks.
Okay, thanks, Alex. I'll take that. Well, I'll go first, and that's okay. I'll take the penalties. So we're not incurring any penalties because we were contracted to Reba Stage 2, and we were able to finish off to that point on the two bigger projects. in terms of the backlog maintenance, we've been asked by Scottish Government to prepare an additional ask for the projects that were halted. So what the implications will be of halting those two projects. So we're gathering that piece of information in just now. But in terms of the wider backlog maintenance, we could always do with more backlog maintenance money, Alex, is the long and short of it. So yes, we are short of where we would like to be. But I don't think that's been an unusual picture for the last number of years in terms of backlog maintenance.
Thanks, Richard. And I can see that Pam and Heleth are going to come in as well. Pam?
Yeah, I was just going to add a little bit more about, you know, some of this work, and it, you know, we're not starting from scratch. We have been, you know, trying to work through and understand our system better for some time now, and just really getting people in that space where they kind of look at how they spend what we have, as much as how do we, you know, where do you pull a saving from? Because you actually, you know, we need to look beyond just the pulling out the savings. So, you know, the real trick here is to get better intelligence about how the choices we're making now and how we're spending the money that we've got. And I think, you know, there's something that actually in that one that relates back to Jerry's comment about the flow of people through our system, and you know, where the activity sits and whether that's the right activity, and whether we would prioritise differently with a slightly different financial framework. So that's the work. And one of the ways into that Heleth has really encouraged is looking at, obviously, the supplementary staff and spend, because that takes you to where perhaps sustainability is an issue, and therefore the questions about redesign and what have we always done that doesn't work for us now versus what might we have to do differently. So there's different ways into understanding the system, and that's absolutely, you know, where the focus is at the moment. And then the big question is, so what does that do if you make that change? Does it have an impact on services in a way that we would see it as significant and unpalatable, versus does it flush out some of the opportunities for change and future-proofing our services? So that kind of frame of working through that, I think, is really important, and that's where we're at the moment. And we're also looking at how we can kind of increase the resource around that urgent piece so that we can get to that point of understanding and good decision making quicker.
Thanks, Pam. Heleth.
Thank you. Just to give you a bit a more accounting response, we have been given assurance that we won't be at financial detriment to any decisions made, and as Richard said, we don't have contractual penalties, but we won't either potentially be able to capitalise the project and some of the work that we were doing in this year. But we believe that we will get AMI cover for that, which is effectively an exceptional spend. So we're working through the accounting treatment impact of this as well. We have included assumptions around backlog and additional backlog maintenance of the other buildings within our financial plan as well. So we have put higher amounts in just to alert Scottish Government of that. Obviously, this is the iterative process of planning now, so we've had no response back. The plan only went in yesterday, but we're already flagging it and highlighting it. And the other impact of the capital element is the revenue. The staff that we have that have been capitalised under projects will now become a revenue cost to us. So again, we're working through that with government, because as I said, they have told us we won't be at financial detriment to the decision. The staff themselves, we'd redeploy easily. There's plenty of work for them to do, so there's no concern then. They can help with some of those redesign work, but there is a revenue impact of it. So again, it's all going through the planning process and is part of that conversation with Scottish Government. Alex, I'm conscious that I didn't answer your previous question as well around the future planning. Within our finance plan, we've put an assumption for future years of 2% uplift, but it's just a working assumption at the moment. We've had no clarity or confirmation on that.
Thanks, Heleth. Jerry, I'll bring you in next.
Thank you, Sarah. A couple of questions, and they're related to 23-24 and 24-25. Helen, when we discussed the month 8 position in a lot more detail at the Finance Committee, there was definitely a sense that the position was becoming a lot more challenging. I'm getting a sense from what you've seen now of month 9 and moving forward that maybe perhaps you're a bit more confident of getting to the Scottish Government target, and I just wanted to get a sense of whether that was correct or not. And probably related to that, I would appreciate an update on where we are with discussions with the Highland Council, both for 23-24 and 24-25. I don't know the exact date, but I should imagine the council are setting their budget within the next 2 to 3 weeks. I know they've got a legal date when they have to set their budget by, and just a broad update on where we are with those discussions. Thank you, Helen.
Thanks, Jerry. Yes, we are. The month 9 position we have finalised now, and it is looking a little bit more positive. So we've submitted a forecast of 54.6 million, and we are confident of delivering that. We're being asked by Scottish Government to improve further on that, obviously, and as expected. So we'll work on that. But we're seeing some more reduction through the supplementary staffing, especially in acute services. So that's really positive. And we're seeing some of the risks around prescribing. So I think I've mentioned previously, we've had some issues with the prescribing system and the recording of that information. So some of our assumptions around the spend has been based on previous year details rather than this year. We've now got information in the system up till August, which is still a fair bit behind, with a commitment that will be up to date by the year end. But the figures were looking more positive than we'd predicted. So we had been a bit pessimistic, I think, in our assumptions. So we're seeing some improvements there as well. So we are confident that we will deliver that 54.6 as a minimum. With regard to adult social care, we are still taking the assumption that we will get in the region of 3 million to offset this year's deficit from the council. In line with the integration agreement, we are going to have to formally write to the council to request that, and but we have set that expectation previously, and we're having conversations around the gap for next year. So the council are aware that there is a 24 million projected deficit. They are aware of our expectation that budget breaks even within the health budget. How we address that is the part that's being discussed currently, in the same way as the way we're going through the health plans and how we reduce our spend. We're having those same conversations with the council currently.
Thanks, Hileth. Any other questions or comments? Okay. So not kind of go over what we already said. Obviously, very challenging, lots of work to be done, a quickly evolving picture as Hileth and teams work through the finer detail of that. We had already stepped up some of our governance around our finance with our increased FRP meetings and other activity. I suppose just to remind board members, and for the benefit of our new board members, if you're not a member of FRP, you can absolutely go along and hear that more detailed scrutiny, and actually that might be really helpful at this time as we're getting to grips with what that means for us in terms of the choices that we're going to need to make coming up. Okay, no other comments or questions, so just check in there. So we were asked to discuss the content of the report, which we have done, examine and consider the implications of the matter, and it is proposed that, for obvious reasons, we take limited assurance at this point. Is everybody, I don't know what the right word is, not content, but that's what we're going to do. Okay, good. I realised also I was clearly blown away by the level of engagement and the number of questions around the IPQR. I forgot to tidy that one up. So just to double check, we obviously noted the continued and sustained pressures facing the NHS and our Commission to Care Services, and we definitely did consider the level of performance across the system, and it was proposed that we take moderate assurance from our IPQR report. So just to check in before we break, is everyone happy with that? Lovely, thumbs up there. Okay, good. Right, that was a really good discussion. I think we've all earned a break, get a little bit of a refresh before we do the rest of the agenda. Let's meet back here at 11:45, please.